I'm David Brown, Director of the Virginia Department of Health Professions. Welcome to Virginia's core competency modules for pain management and addiction. These competencies were developed by work groups convened by Virginia's Secretary of Health. Over 24 experts in pain management and addiction compiled the essential competencies that Virginia's health professional students must acquire, not just our future physicians, nurses, dentists, and pharmacists, but the wide range of professionals who work with these types of patients. These modules, made possible by a Department of Behavioral Health and Developmental Services grant, present key parts of the competencies for use not only by our schools, but by practitioners already in the field. Thank you for your careful attention to this important information.
Hi, I'm Megan LeMay. I'm an assistant professor of general internal medicine at Virginia Commonwealth University School of Medicine. I spend most of my time as a primary care doctor and clinician educator, and some of my time at VCU's Motivate Treatment Addiction Clinic. And I'm really excited to talk to you today about how and when to refer to specialty care for addiction. Today we're going to practice an individualized, multidimensional assessment of a patient presenting with a substance use disorder. We're going to use that to match a patient's needs with the level of substance use care and utilize resources to locate substance use treatment for patients. So, which patients need referral for treatment? Any patient with a current moderate to severe substance use disorder should be referred for addiction treatment care. Any patient with a history of a substance use disorder who's at high risk of relapse or serious consequences of substance use should also be referred. Which patients are at high risk of relapse? Patients may be high risk if they have active psychiatric problems, difficulty sleeping, poor social support for recovery, low motivation, high levels of stress, or a history of multiple prior treatments followed by relapse. Which patients do you see that might not require a referral? Patients with a mild substance use disorder or hazardous substance use don't necessarily need to be referred for treatment. And in this case, you can perform a brief intervention in the office. A brief intervention for patients that don't require a referral might look something like this. You first elicit their permission to discuss. For example, may I please talk with you about alcohol use? Then you provide them feedback and enhance their motivation, such as describing safe limits of alcohol use and some of the negative consequences specific to that patient for drinking, and motivational interviewing techniques to help allow your patient to identify reasons why this might be important to them and how they might change. And lastly, elicit their response to that discussion and set goals for the follow-up appointment. So let's start with the case of Mr. White. Mr. White is a 54-year-old man with a history of opioid use disorder, presenting to primary care clinic stating, "I need treatment for my addiction." He recently overdosed on heroin, but is still using heroin 4 times a day. Most recently, he used yesterday, and he's currently in withdrawal. He asks you what to do next. This is a multidimensional assessment from ASAM, the American Society of Addiction Medicine, that's going to help us assess what level of care Mr. White might need and what's going on with his addiction currently. Dimension 1 is acute intoxication or withdrawal potential. And this is talking to a patient about their current or past experience with their substance withdrawal. Dimension 2 is biomedical conditions and complications. This is a patient's health history and current physical condition that might affect their treatment. Dimension 3 is emotional, behavioral, or cognitive conditions and complications. And this is exploring an individual's thoughts or emotions about mental health issues and their current status. Dimension 4 is readiness to change, or exploring an individual's readiness for treatment or other changes associated with their addiction. Dimension 5 is relapse, continued use, or continued problem potential. This is sort of a patient's experience with treatment and relapse or continued use. Dimension 6 is their recovery or living environment, and this is exploring their living situation and surrounding people, places, or things that might affect their treatment and recovery. We use this information to decide what level of care a patient might need for their substance use disorder. And this is adapted from the American Society of Addiction Medicine. And what to focus on is the 4 main levels of care at the top, which would be 1, outpatient services, 2, intensive outpatient or partial hospitalization, 3, residential or inpatient services, and 4, medically managed inpatient services. For level 1 outpatient services, this is addiction treatment that's offered in the outpatient or office-based setting. And patients appropriate for this level of service would be patients who have medical, housing, and psychiatric stability, are motivated towards treatment, and have not had a lot of experiences with relapse or complicated withdrawal. The next level of care is intensive outpatient or partial hospitalization services. Intensive outpatient programs offer patients at least 9 hours a week of treatment and care, and partial hospitalization offers at least 20 hours a week, where patients may spend most of their daytime at these programs receiving treatment and then return home at night. This level of care would be appropriate for patients who perhaps have experienced relapse in the outpatient setting or are stepping down from a residential or inpatient service. The third level of care is the residential or inpatient services, and this ranges from sober living houses where patients may go and live with peers and sometimes staff who support abstinence from substance use, to medically supervised inpatient services. Number 4 would be medically managed inpatient services. And the most common use of this is in medically complicated withdrawal. And this can be detox in a treatment center or withdrawal management in an inpatient setting. There are multiple modalities of care for the treatment of substance use disorders. There's addiction counseling, psychotherapy, pharmacotherapy, and mutual help groups such as Alcoholics or Narcotics Anonymous. Any of the combination of the above may be recommended to patients with substance use disorders, with the exception of making sure that we always recommend medication-assisted treatment be part of treatment for opioid use disorder. Let's perform Mr. White's multidimensional assessment. For number 1, acute intoxication or withdrawal, he currently has opioid withdrawal symptoms including craving, diarrhea, muscle aches, and runny nose. For dimension 2, biomedical conditions and complications, he has a history of hypertension, which is well controlled on medication, and recent lab work showed normal kidney and liver function. For dimension 3, emotional, behavioral, cognitive conditions, he does have a history of depression and currently feels depressed, though not suicidal. He has been on medications for this in the past. For dimension 4, readiness to change, he feels very motivated to change currently. He feels he's hit rock bottom after being kicked out of his daughter's house after she found needles in his room. Dimension 5, relapse, continued use, or continued problem potential. He has been to mutual help groups for opioid use disorder twice before and relapsed both times within a month. For dimension 6, recovery or living environment, he currently lives with his mother, who is supportive, and he's away from the neighborhood where he usually uses. Based on Mr. White's multidimensional assessment, what level of care should we refer him to? Based on the fact that he has medical, psychiatric, and housing stability and a high motivation towards care, he would probably be appropriate for either outpatient services or intensive outpatient partial hospitalization services. And to decide between the two, it's essentially a discussion with Mr. White about what's available in his area and what he feels would be best. Let's perform this assessment for another patient. Ms. Gray is a 61-year-old woman with a history of alcohol use disorder, stimulant use disorder, seizures, coronary artery disease, and she's presenting for treatment of her alcohol use. She describes feeling shaky, sweaty, and like she has a fast heart rate. She drank alcohol 11 hours ago and used cocaine last 2 days ago. Ms. White currently has a CWA score of 13, indicating moderate to severe alcohol withdrawal. Her breath alcohol level is 0.06. She has had several alcohol withdrawal seizures in the past and has been in the ICU for alcohol withdrawal several times. She has a history of a cardiac stent placed 3 months ago and currently has a heart rate of 113 and a blood pressure of 162/98. She has a history of bipolar disorder, but stopped her medications 2 months ago due to side effects. She's worried about her medical and psychiatric issues and feels very motivated to seek treatment for her substance use. She has been in treatment with Outpatient Addiction Clinic twice, but drank alcohol and used cocaine through treatment. She has been hospitalized for alcohol withdrawal, she says, more times than she can count. She's currently homeless and spends most of her nights on a friend's couch, but unfortunately, he drinks heavily. So based on Ms. Gray's multidimensional assessment, what level of care should we refer her to? Based on the fact that she's currently in acute alcohol withdrawal, she should first be referred for medically managed inpatient services, either at a detox center or an inpatient hospital. 2 weeks later, Ms. Gray has completed her inpatient treatment of alcohol withdrawal, which did require a stay in the ICU. She's now fully recovered and ready for discharge, and she asks her medical team where she should go now. I want to use this case to sort of describe that all of these levels of care are a continuum, and people can move among them as treatment of their substance use disorder changes. So now that she's stabilized from the medically managed inpatient service, she would be appropriate to step down to either a residential inpatient service or an intensive outpatient or partial hospitalization treatment program. So how can you refer patients for substance use disorder treatment? It's important to use the interdisciplinary team you have where you work, including social workers, care coordinators, and peer support specialists, and to become familiar with the resources available in your area. A referral may depend on a patient's insurance status, as not every treatment program may offer treatment to patients with all types of insurance. And treatment within primary care should be considered if that's available and appropriate for the patient. The first resource I'd like to introduce you to is the Samsa Helpline. This is the Substance Abuse and Mental Health Services Administration National Helpline for referral for care. It's free and available 24/7, 365 days a year. And on the other line, you will find someone who is able to search for resources for substance use treatment or mental health treatment in your area. Paired with this is the Samsa Online Treatment Services Locator. And here you can put in an address or a zip code. And then it provides you a map and a list of services in your area for the treatment of substance use disorders and mental health. I want to point out that this tool I find really helpful because you can click whether you want to have a patient seen for substance abuse, for mental health treatment, or both. And you can also choose if you want to specifically search for someone who is a buprenorphine provider. In Virginia, every county has a local community services board. The Virginia Department of Behavioral Health and Developmental Services establishes these community services boards in each county. And through them, you can get rapid access to care, including for patients without any insurance. What should you do for patients who are resistant to treatment? First, it's important to respect their autonomy in their decision-making for their health and the stage of change where they are. Assure them that you will continue to care for them and provide them the brief intervention that we discussed earlier. You should also consider harm reduction strategies, such as prescribing them naloxone or referring them to a needle exchange if they are using opioids. You should schedule follow-up for your patients with substance use disorders and know that relapse is an expected part of this relapsing, remitting chronic disease. So even if they've been referred for treatment and relapsed, you should continue to care for them. Also, once you've referred somebody for substance use treatment, know that there are additional privacy laws for substance use disorder treatment, meaning the provider on the other end treating them in the specialized setting needs special permission from the patient to discuss care with you. In conclusion, any patient with a moderate to severe substance use disorder should be referred for the treatment of their substance use. Utilize a multidimensional assessment to match patients with the appropriate level of care for their substance use disorder. And also utilize the interdisciplinary team and local resources to locate care for patients. Some of the most helpful resources are the Samsa Helpline or Online Treatment Services Locator and the Virginia Community Services Board in your county. For patients who are treatment resistant, consider brief intervention and harm reduction. These are links and numbers to the resources that we discussed. And I just want to thank you for joining me and learning about this topic, and best of luck in treating your patients.